Thank you so much. I'm really quite thrilled to be here. I'm assuming you can hear me. And I did not test this out. Okay. Okay. So you all are a quite varied audience in terms of background and age and what you're doing currently. So I hope that there'll be at least something for each of you in this talk. And I hope that you'll ask a lot of questions at the end. So I'm going to start with Mrs. B. I hope you can see her. She was a participant in our pilot study for the capable studies that I'm going to talk about. And Wojtek could not have set up my talk better if we had planned it out. So he talked about the history of a whole field of research. I'm going to be talking about the much smaller history of an interest, a clinical experience that led to a series of research, a program of research. And it's all based around the principles he talked about. It's all based around people's own goals, menus of choices, sustaining what they're doing, and getting people back from below that disability threshold that he talked about into a much more comfortable place in terms of ability. So, it's almost as if we'd planned this. So for the nurses and physicians and perhaps pharmacists and other folks in the room who are clinicians, Mrs. B has hypertension, diabetes, congestive heart failure, and arthritis. Very typical problems for someone who's 85. If she made her way into your office, if you're a clinician, for people who don't know the research about goal setting and motivational interviewing, in general, we take shortcuts and we say, these are the 20 medications you need to be taking. Are you taking them? Are you getting enough exercise? Okay, let's check your sugar, let's check your blood pressure, see you in 3 months. That's what we do with Mrs. B in general. There are certainly standouts who don't do that. But Mrs. B has those conditions. But what matters to her is that she can't get her foot over her tub to take a bath. She can't stand long enough to cook. She can't get down her front steps without someone, almost holding her. And that's what matters to her. It's also what drives healthcare spending. So we have a great opportunity to leverage current health policies to address her physical function. So, as I said, if she came to see you in the clinical office, you would address her medical issues and tell her what to do. And she'd walk out the door. And she'd probably have a lot of questions that she didn't manage to ask. And she wouldn't really be better off. Now, I'm not saying that it's not important to address diseases like hypertension and diabetes, because those do lead to physical function. But if you think about it, why do we care about high blood pressure, for example, or diabetes? The reason we really care is because eventually it could give us a heart attack, or eventually we might have to have the leg partly amputated. And the reason we care about those is because we wouldn't be able to function, right? It's because we wouldn't be able to go volunteer, or we wouldn't be able to cook dinner for our extended family. The reason we care about diseases is because of function. But the medical community ignores function. They just try to control the diseases in general. So as Dr. Kirkpatrick mentioned, I'm a nurse practitioner with a PhD, and I did house calls with low-income older adults for years and years. And I was that person I'm mentioning. They were the exact same kind of visit as they would have been in a clinic. I would go to someone's home, it'd be falling down around them, there'd be holes in the floor, I could see all the problems, and I'd be saying, let's see, have you taken your metformin? Have you taken your diuretic? Oh, you're not taking it? What are we going to do about this? And then I'd leave. I'd offer to reach something for them, or I would see you can't grab this, can I help you? I was nice about it, but the clinic visit was just completely transformed to their home environment, even though I had priceless evidence of what their real barriers were. So I thought, well, I'm going to do something about this. And I got a PhD and decided that I was going to devote my research career to changing some of these issues. And I knew, I was actually a lobbyist before I was a nurse. And my job as a lobbyist was taking nurses around Capitol Hill, helping them talk to congresspeople. And listening to all their stories, I thought, wow, their job sounds a lot more fun than my job. I want to go be a nurse. And I knew that I wanted to always be involved in health policy in some kind of way. So based on my political lens and knowing the levers of what politicians and communities care about, I thought, you know, if we can solve the issues for someone like Mrs. B, she will be happier and society won't have to pay as much, right? Because she's one fall away from being in a nursing home. Or you know, if you can't take a bath, if you can't eat. I mean, she was, well, the first time I met her, she was very hungry and she's ripped open the food that I'd brought her and ate it right then. Even though, you know, I think that that's not how she wanted to behave, right, with someone she hadn't met before. So framing, we have great leverage in terms of older adults to spend money to solve some of these problems because we're preventing nursing home admission, which costs all of taxpayers a lot of money. Sadly, with middle-aged adults don't cost society right then a whole lot of money, and so it's harder to leverage the political will. So I kind of put together my clinical experience with my policy knowledge. And now this is more for the students in the room. Everyone else can zone out if you'd like. But so I was, you know, what are we going to do? Like, how do you go from having a clinical insight, a vision, to developing a program of research? It can be an intimidating process. So the great thing about being at a wonderful place like Purdue or Johns Hopkins is you have a lot of colleagues who are smarter than you are and who have a lot more experience than you do. And when you're young, and I'll say this about myself, you're much more ahistorical, right? You just think, no one has ever thought of anything before, and I'm going to solve this, and I have no knowledge of anything for me. And that's why a talk like Vortex is so great, because you can see the progression over decades. And so for the graduate students, you know, talking as much as you can about your idea and formulating it in many ways to people who are not ahistorical and do know the literature and can point you to what you've missed so far. Identifying a funding opportunity, even if it's small. The first grant we wrote for the Capable project was when the recession first started. There were these stimulus grants from NIH, and everyone that I knew was writing at least one. And I knew we wouldn't get it funded. It was clear. But I thought, well, we'll get comment. We'll see what other people think. And then, of course, it's iterative, right? You present your ideas. People say, no, that's not a good idea, or that won't work, or why don't you try it this way? And I promise I will not spend long on theory. Some people see the word theory and they just either fall asleep or want to throw up. But I have to say, you know, if you get invited somewhere by Ken Ferraro, you have to throw a little theory into your talk, right? And as Kurt Lewin said, there's nothing so practical as a good theory. So you know, you go to some of the foundational theories of your discipline and of related disciplines, and they are extremely practical. And this is the last theory and behavior intervention slide, I promise. This is a very, very handy template, which you can see is exceptionally simple. But if you start with what the theory base is and what you want to get done, then divide up what you want to get done specifically, and then tasks that would make you get that done, and then measure what you were trying to do that would affect the concepts in the theory. Theory is so straightforward, and we tend to think of it as something that is unreachable. But for the graduate students, I'm just trying to tell you theory is really useful. So back to Mrs. B and our story. So this line across the 1 is essentially the average. It's the relative probability for the general population that someone will be in what they call the top 5% of healthcare spenders. Now, economists use that term, spenders, as though people are just spending their money on going to the hospital and going to nursing homes. It's a terrible term. But what they mean is, so another way of saying it is high-need users or high utilizers. And the point of this slide is that if you have no problems and no chronic conditions, right, you're likely to spend less. Makes sense. If you have one chronic condition or two, you might cost the healthcare system a little more. And this is what we tend to focus on, right? These are the diseases. But you'll see that the really steep incline is when people have trouble with taking care of themselves. These are chronic and functional limitation. And then let me just introduce the concept of ADLs and IADLs for people who don't study aging. So ADLs are activities of daily living. They are things like bathing, grooming, dressing, walking across a small room, the things that you don't want someone to do for you. Nobody wants to be bathed, right? The IADLs are called instrumental activities of daily living, and those are things like light housekeeping, getting food in the house, managing your medications, and those things, a lot of times people don't really mind if someone does for them. Like, they don't mind if someone sets out a pill box for them and they take the pill every day. I wouldn't mind if someone cleaned my house. You know? But so they're different. And also, we'll get to this later, they're gendered a little bit. So there are, most people do their ADLs for themselves. The IADLs, in certain cohorts of older adults, women have done more of them than men. And so it's a little, that presents a measurement issue also. But the point of this slide is that functional limitation drives healthcare spending in this country. And yet we still ignore it, which is not wise from a policy point of view. So this is Mrs. B's closet. And if you can see her here, this is the first floor of a row house. And at some point, a family member moved her bed downstairs because she couldn't get up the stairs anymore. And so what looks like a window, that's actually her front door. And this room is what used to be her dining room. So there's no closet. People don't have closets in their dining rooms. And she pretty much sits in that chair all day. There's a TV here, and there's a commode here. And she can make it into the kitchen, but barely. And then she just kind of swipes something for food. She's lucky in that she has a grandson who's a truck driver, who, when he comes through Baltimore, he fills up her freezer and her fridge with food, which is wonderful. But she can't really stand long enough to prepare food, so she just comes grab something that's packaged. But this is before she met us. And her closet, this is like a sweater bag you would get at a Walmart or a Target. And you can see it's actually safety pinned together because it's broken. And she's got terrible arthritis in her hands, so she can't really even get to her clothes. So she sits in that house dress all day. This was her floor after we fixed it. So Dr. Kirkpatrick mentioned that we have a handyman as part of our study. And so she had holes all along her floor. And you wouldn't want that for a young person, but certainly not for an 85-year-old who has a little bit more of a shuffling gait, right? And this is what I'm talking about, that in terms of her function being related to her house. And these are her back stairs. That's not safe for anyone, right? And that's like a $40 fix. Okay, so just back to theory for 1 second. Fabergé and Jetty, who are some of the most famous theoreticians, talked about disability being the gap between someone's environment and what they can do. Basically, the gap between the person and their environment. So one way of thinking, and Wojtek talked a little bit about, the house that someone moved into when they were younger. So imagine if you right now had knee surgery and you couldn't do stairs for a little while. If you lived in a one-floor house and you could do everything else besides stairs, you wouldn't be called disabled because you could do what you needed to do. Whereas if you lived in a two-story house, for the time you were healing, you might be called disabled because you had to go up and down the steps and you couldn't. You're the same person. It's the house that's different. So we talk about disability being this gap between whatever environment you're in and what you can do. Well, so if it is a gap, to me, it makes a lot more sense to approach it from both sides, right? From the environment side and the person side. But in medical care, we tend to just focus on the person. What's your sugar level? What's your blood pressure? You're not strong enough. You should try harder. And we don't focus on people's houses. Some local area agencies on aging will sometimes give you a ramp or a raised toilet seat, but it's not together with approaching it from the person side as well. So we developed Capable. So Capable is based on people's own strengths and their own goals and their own disabilities. And it is client-directed, not just client-centered. And right now there's a big movement called patient-centered medical homes and patient-centered care. And I'm sure you do it better at Purdue than we do it. But where I'm from, a lot of times what that means is the person's in the center and all the services around them telling them what to do, which is not, in my mind, patient-centered. So we call ours patient-directed, which I'll tell you about. We have a handyman, a nurse, and an occupational therapist who all work together, and it's time limited. It's over 4 or 5 months. They get 6 visits with the occupational therapist, 4 with the nurse, and a handyman budget of $1,300 that includes home repair, like fixing holes in their floors, home modification, like putting up grab bars, and then assisted devices. So like if someone needs a walker or if they need a crock pot because they don't have any teeth, for example. And importantly, speaking of not being ahistorical, my research is built on top of a lot of other research, right? When you do research, you're really putting up a new brick in a wall, and that brick is on top of a lot of other bricks. And most importantly, it's built on top of Laura Gitlin's work, who got a PhD here in sociology. She's an applied sociologist. And she developed what's called the ABLE program that was tested with a randomized controlled trial, a very cost-effective program. And that's why we're called Capable, because we added on to ABLE. And her program had the occupational therapist and a little bit of home modification and had the same principles that I'm about to explain to you. So we did a pilot in 2010 that's published in the Journal of American Geriatric Society. And in that pilot, we had 41 people, and they were randomly assigned to either getting the services that I just talked about, the nurse, the occupational therapist, and the handyman, or getting an equivalent amount of attention, which is very important, right? Because we all know social isolation is debilitating. And I don't know if you know this, but that loneliness is as bad for you as smoking 15 cigarettes a day, physiologically. And so to be a true randomized controlled trial, we didn't want to get to the end of the trial and have people say, well, you know what, maybe they just did better because they had these nice people coming to their home. So when people were randomly selected for either getting our Capable services or the attention, they got 10 visits over 5 months with the same amount of time, really lovely people. And they did improve some, which was wonderful. So this is how Capable works. It's 4 to 5 months. We collect data at the beginning and at the end, and also now in our larger trials, also 12 months after the first baseline visit, so that we can see, are we continuing to improve over time, or at least not fall right back. And the occupational therapist has the first 2 visits. Occupational therapists love it. Are there any occupational therapists in the audience? No? Okay. Usually I can tell if there is one because they're going like this the whole time I'm speaking, because they focus on function, particularly function in the environment is the OT bailiwick. So I just don't even have to say a word. They're just, and the occupational therapists love this approach because they get to start. And in home care, an occupational therapist can't open a case. They have to, a nurse has to, or a physical therapist. So anyway, small detail. And so the occupational therapist goes through every single ADL. Remember I mentioned those are things like bathing. Can you get into the bath? Grooming. Can you get dressed? Can you wash your hair? Very basic things that we all have to be able to do to take care of ourselves. And the occupational therapist goes through all of the instrumental activities of daily living and asks them how difficult they are to do and if they care about doing it, if it matters, do they want to work on them. And sometimes someone will say, no, you know, my daughter does this part for me and I want to work on this. And there is never any time where we say, well, you should really want to do that. Same with fall prevention, and I'm going to get to how a lot of what we do is fall prevention. We just don't call it that. On the second visit, the occupational therapist goes to every area of the home that the person uses. Sometimes they don't go up to the 3rd floor. They have no interest in going to the 3rd floor. We don't go to the 3rd floor either. Although it's very funny. We've had such great success that sometimes someone, who only could stay on one floor now can go upstairs, and they get up there and they realize their children have been storing all kinds of stuff up there. And the children thought, well, she's never going to go upstairs again. Or same with basements. People, oh, I'll do your laundry for you, Mom. Don't worry, you don't have to go down there. And then it turns out, they've got lots and lots of stuff. So that's been a funny part for us. So then the occupational therapist and the older adult develop a work order together for the handyman. We call it handyman. It's really a sexist term, handy person, but handyman just kind of rolls off the tongue. And the handyman is with a nonprofit organization that also does job training for young adults. And so it's a really nice two for one, where the younger adult is getting, learns more about what older adults go through, and also is getting some job training, and there's a more senior contractor. So there's two people who go into the home. This is done by the participants' priority order, and nothing is cosmetic. We don't do anything. These are all taxpayer dollars we're using, right? And so we don't do anything that is, painting the walls or that might brighten it. That some people would say we should pay attention to aesthetics, but it's much more around the function. Then the nurse starts. And so I think there's some nurses in the audience. The nurse, it's a very different role than a regular nursing role. And it takes, when we train nurses, it takes a little bit of a mind shift. For one thing, the nurses tend to say, well, what about my goals? When do I get to check their sugar? And it's a really big shift to say, okay, we don't have any goals in this. It's all about what they want to do. And so the nurse assesses, similar to how the occupational therapist assesses the domains. The nurse looks at pain, mood, ability to take or not take the medication. Sometimes people are on 40 medications, they don't know what they're for. The ability to communicate or not with their primary care provider, and if they want to work on that, and then strength and balance with very, very simple exercises, things like choir clap, and we've got a whole booklet that's evidence-based. And so, so for example, with pain and mood, the questions are about function. So we'll say things like, because if you just ask a blanket question, are you in pain? Someone might say no or yes. But if you say, does it hurt when you try to put a sweater over your head? Or are you in too much pain to reach a pot or pan, down below? Then you get the real answers. Oh yeah, it hurt. I never can get dressed, doing this, or I can't lift that pan because it hurts. And so the nurse has nursing domains, but they're all about function. And so then they come up with the goals on the nurse side. So sometimes they're the same goals as the occupational therapist. For example, we have people who sleep on their couch because they can't get upstairs. And their goal might be, I want to be able to get up the stairs and sleep in my own bed. That could be the nurse goal and the OT goal, because the OT would be ordering banisters on both sides of their stairs and lighting on their stairs and teaching them energy conservation tips to be able to try a little bit and rest, for example. And the nurse might be working on pain in the knees and how to take different medications at different timing for going up the stairs. So it could be the same goal. Or the nurse goal might be, let's say, fall prevention, which we'll talk about in a minute, and the OT goal might be preparing food in the kitchen. So they could be different goals. But they're all wrapped around with the person's own goals, and they're very specific. And so then the visits go throughout the time, and just to build on Wojtek's talk, we use all of that wealth of knowledge that he mentioned that over the years people have gotten about using people's own motivation. And so they come up with their goals, and then on each one of these subsequent visits, they pick whichever goal they want to start with, and they brainstorm. Well, could I do this, or maybe I could do this? And I'm going to tell you a couple patient stories so you can understand what I'm saying. But it's all built around the science of self-efficacy and building on small gains. And here's just a visual example. 2 85-year-olds lived in this house. And if you've ever had any leg weakness, you know that you pretty much just have to hurl yourself down. If you have nothing to lean on, that's just a crapshoot, excuse me, for, every day. So we put up these 2 banisters. You can see we don't paint them, we don't stain them. It's not about the looks. But wouldn't you rather go down those steps? And a banister costs about $70 to put up. That's nothing in the healthcare realm. It's a lot of money if you don't have much money, but it's nothing compared to healthcare expenses. So I'm going to show you a little data, and then I'm going to tell you some stories about, so you can really get it in your head about how this works. So we've been very lucky with a lot of funding, which has been a nice complementary study. So we have a large randomized controlled trial from the National Institutes of Health. And for that, people are either randomized to the services we've been talking about or those attention visits. So we'll be able to really tease out how much is the social engagement and how much is the actual capable services. For that, we're also getting all of their Medicare and Medicaid spending for the whole time they're with us and 2 years after. And so for the control group and the group who's getting our services. So we will have a very good picture of whether we're saving money as well. We had and how am I doing on time? Oh, good, okay. We have, so when Obamacare passed, there was a $10 billion appropriated for $1 billion a year for innovations that could save costs and improve people's lives, and we got one of those grants to study that. And then in Michigan, they're picking up capable within what's called their Medicaid waiver, which is for people who are eligible to be in a nursing home but want to stay at home. We have colleagues who are piloting in Australia. And then in New Mexico, a plan in Albuquerque and Santa Fe is picking it up in a year. And then Greensboro, North Carolina, and San Diego, California are starting it in January, and a small city in Maine is also. And these are some of our publications. So what I can take you through, we do not yet have the data for the large randomized controlled trial because we're blinded, meaning we don't know who's in the control group and who's not, and we're not allowed to we're not allowed to unblind, right? So what I've got data is from the grant that's through the Obamacare, and then that one, everyone got the services. They said, we're a healthcare insurer, we're a healthcare payer, you can't have a control group because we can't be paying money to people who are getting, in our minds, nothing, which is reasonable, right? They are Medicare and Medicaid. And so they are helping us construct a comparison group of people we have not met who have similar healthcare utilization at the beginning, and we'll be able to compare costs over time. But we won't be able to ask those people any questions. We won't meet them. So this is really the money slide. So if you can picture that slide I showed you about the healthcare spending going up when people have functional limitations, we're showing that this is modifiable. So this is what's called a spaghetti plot. And so each line is a person's outcomes. And they start at baseline here on the left. They can have up to 8 different ADL difficulties. So if they have 4, it might be they have difficulty getting off the toilet, difficulty bathing, difficulty grooming, and difficulty getting dressed. Those would be 4 different areas. And on average, people come in with just about 4. The average is the red line. And then you can see we're pretty much cutting it in half to 2.1. And so if you can picture that slide where people cost more when they had more ADL difficulties, you can see we're backing them up along that healthcare utilization. We don't know that yet because we don't have the cost data yet, but this should pan out. And what's more important is people are thrilled that they can take a bath or that they can get themselves dressed, right? And the stories people tell us about being able to take a bath now for the first time in 5 years, or being able to go, one person said, I don't have to get an army to get me off my front porch anymore. Or I can take a bath that's better than winning the lottery. So this is really the story about the humans involved. And when we look at the people who, as you can see, some people do get worse, right? We're talking about over time with very low income older adults. You would expect that over 5 months, some people would do worse, right? There's people who've had strokes in this 5 months. There's people who've gotten cancer in these 5 months. There's people who've had a fall. So there are some people who get worse, but you can see that the average is really cutting it in half. Another way of looking at the same data is that 75% of the people are improving. And for improving and staying the same, both of those are essentially a victory because it's over time, right? And so only 10% are declining over that 5 months. And this is really, really pretty remarkable. And it's all because it's around their own goals, is what I think. And that the overlap between the OT, the handyman, and the nurse together. One thing we're also really proud of is these are depressive symptoms, and the red line, again, is the average. And this is actually a clinically meaningful difference. It's like an antidepressant. It's about the same strength. And we're not giving anyone any pills, but they're able to do what they want to do. It's like being freed in their own life. And another thing we're really proud of is that if someone is depressed, this is just true in general in life, not necessarily in our cohort. If someone is depressed, they have worse daily functioning. And that's bidirectional, meaning the depression can cause the worst functional, and the worst functional can cause depression, right? That's true when we enroll people, that we've noted, there's a strong correspondence between depression and ADL difficulty. But when we look at it, everyone improves pretty much on that. So even the quite depressed people are improving on their ADL function. And it's because it's tailored to what they want to do, right? It's not a standard thing that we're doing. There's standard aspects, but the actual what we're doing in the visits has to do with what they want to do. And so the people who come in quite depressed or moderately depressed or mildly depressed are all doing better with their daily function by the end. Not all, but 75% of them are. And this is basically the same slide showing they're going from about 4 to about 2 ADL limitations, but divided up by whether they've been hospitalized in the last year. And so the point of this is to show you that even quite vulnerable people who've been hospitalized are doing just as well in terms of cutting their ADL limitations. In fact, it's a steeper slope, meaning that they're actually doing a little better considering that they started off worse. And this has really large implications because you probably all know someone who's been in a hospital. Before they got in the hospital, they could do all kinds of things. When they get out, now they need help doing something, or now they can't drive, or now, and that's for all kinds of reasons, right? Hospitals are terrible places. They wake you up in the night, your timing's all off, and also for whatever reason that you went in. So we're very pleased about this as well. So can someone tell me how much time I have? 15, okay, great. So I'm just going to tell you two patient stories so you get a sense of how it actually works. Mrs. D, she was actually the first person in the Obamacare one that we had, the Affordable Care Act one that we have, and both the occupational therapist and the nurse came to me after their first visit and said, I don't think there's anything we're going to be able to do for her. I'm sorry, I don't know how she got into this study. She really needs to be in a nursing home. I'm sorry. And I said, well, let's just think this through, work the program. This is a study protocol. We'll just take it one step at a time based on how it's designed. And so, and on the first day, if you see this second bullet, on the first day when the occupational therapist had her demonstrate what she could do, it took her 30 minutes to walk from her bedroom to her bathroom. And it was about from here, I've seen it, about from here to that door. It took her 30 minutes. She had a walker, and she was so weak. And so consequently, she didn't go to the bathroom. She sat on a commode chair all day long in her bedroom. And that was the only hard surface there was. And her poor husband was also in his 80s, and he was a very slight man. And he would just lift her up and put her on the commode chair. And that was like all he could do. And he was just exhausted. And she was confused and over-medicated, and she would just sit there all day, and people would do stuff for her. And she had a terrible quality of life. And so the first thing the nurse did was realize how many medications. She was on 26 medications, many of them for pain, and she took them all at once in the morning, and so she was just completely out of it. And so the nurse made her this beautiful little medication calendar, very common sense. It's just divided up, showing her suns and moons and afternoons and the name of each medication in common language as well as the official name and how she should take it. And once Mrs. D got that straightened out, she started to be alert, and she really wanted to work the program. And so with her next brainstorming visit with the occupational therapist, she came up with the idea, her own, Mrs. D, that for shortening, for that distance from about here to the bathroom, if they had little plastic deck chairs, like the kind of chair you might have on your deck, every couple of feet, that she could get to one and sit down and rest. and get to one and sit down and rest. And I can tell from you all being here that you wouldn't have to rest every 2 feet. But for someone who's been sitting in a chair, right? Am I right? Okay. That's some exercise to walk 2 feet. It's sad that that's exercise. But she was huffing and puffing. And so she rests. And so she then, for her homework, essentially, she would do that. And then gradually we took, she with her family took away a couple of the chairs and she could get, and still by the end of the study, it still took her 7 minutes to get to the bathroom. So that's still a long time to walk a short distance, but it's a huge improvement, right? And her goal, and this to me is a good lesson in not imposing our goals. Her main goal was to be able to get down her stairs. She lived on the 2nd floor, and wash her hair in her sink. And when I first heard that, I thought, in my head, really judgmentally, that's a silly goal. Why did she care about that? Of course, I did not say that out loud. And I'm so glad that she was the one who came up with her goal. She was really motivated to get downstairs and wash her hair. And so besides building up her strength, we put banisters on both sides of her stairs, and that she'd been working with the nurse on the strength and balance exercises. And when she got down the stairs, her husband burst into tears. It was just such a moving moment. And her daughter actually called us about 6 months later and said that the whole family, including her, had gone to Atlantic City for a vacation. And she had not been out of the house except for doctor's appointments for several years before we came. And so she's actually, on one of those slides, I have to take you back. She's actually the person who went from 8 to 0 in the ADL limitations. And I've witnessed it, and I can tell you it's true. It was not measurement error. And so I think she's a really good example of, she went from sitting practically comatose on the top of a commode all day long to being able to go to Atlantic City and support the economy. And other really inexpensive things we did for her was, remember I told you that her husband would haul her out of the bed. There's bed risers that cost about $7 or $10 that they're just hard pieces of plastic that go under the 4 corners of your bed. So her bed is taller, and we have a nice clamp grab bar for her. So she can actually lift herself out of the bed now. And we got her a wider commode because she's a large woman, and she still sits there sometimes, which is fine. That's what she wants. But she can use the whole house, and she can wash her hair in the sink downstairs. So one more, I'll tell you another one. This was a woman, and these are actually, I love this. This participant took we have an exercise book that has pictures of people doing them, and she ripped up her book and pasted it on her closet door so she could see them all so she could do them in the morning. That wasn't something we suggested. But so Mrs. H, she had asthma, diabetes, hypertension, and arthritis. And when we first got her, she couldn't bathe or get dressed or cook because she was too breathless from her asthma. And it turned out, as we questioned her, she only had what are called rescue inhalers, which are something you use kind of an emergency. She didn't have preventive inhalers, and that's a very simple fix. She should have been on, if you have a certain stage of asthma, you should be on preventive inhalers. So we got her switched by working with her primary care provider to the better kind of long-acting inhalers. And she was in a lot of arthritic pain, but she never took her medication because it bothered her stomach. This is a very common thing for older adults. There's a certain kind of medications you shouldn't really be on for long if you're an older adult. And if you're lucky, it hurts your stomach because it's actually a signal that you could be starting to bleed from a bleeding ulcer. But she didn't know that there were alternatives. So this is a simple thing. We switched her along, consulting with her primary care provider from Aleve to Tylenol. Tylenol does not hurt your stomach. She did the capable exercises. We did a lot of modifications around her bath because for her best pain relief was to get into a deep bath. That's what she loved to do, and she couldn't do it before we came along. And now she can. She also was quite hard of hearing. And even if she could sit in the first row at church, she couldn't hear the pastor. And this was very upsetting for her, as you might imagine. And also she was a deacon in the church. And so she couldn't participate as fully as she wanted to. We got her a $35 thing. Maybe some of you know about this. I did not. There's $35 instruments called super ears. And they're about the size of like an iPhone. and they have a microphone in them, and you point them towards what you want to hear better, and you have little earbuds like you see people walking around with. So it's not as, it looks, you can tell someone's using something. It's not as, nice looking as a hearing aid, but they're $35. Thank you. And so she sits in church, and she points it to who's speaking, and now she can hear. And so the combination of being able to bathe herself, being able to be in less pain, being able to hear people, she looked me right in the eye, and she said, if I had 10,000 tongues and they could all speak at once, I couldn't praise the capable program enough. And she has said, I will go anywhere for you, do anything. She's been on videos for us. We also repaired a few things in her house, but she's a good example. A lot of times with older adults, there are small things. Like these are all tiny things I just talked to you about. There's no rocket science in here. There's no surgery. There's no giant medication change. These are tiny changes based on what she wanted to be able to do that we could use our clinical expertise and modifying the home to really transform her life. So to sum it up, poor function costs our society a lot of money, and it's what people care about generally, and it's virtually ignored currently, and it's modifiable. So it's just this perfect storm of let's do this. We also are at a really interesting time from a health policy point of view. So whether you were for the Affordable Care Act or against it, all of healthcare is moving away from procedure-based service reimbursement to value-based. So what that means is currently, if you're a hospital, for example, you need people to have heart attacks, to break their hips, to fall, to have bad things happen to them, because that's how you bill. That's how you survive. If you're a doctor, you need to do certain procedures. You are trying to do more and more procedures. Of course you care about the individual who's in front of you, and of course you have a therapeutic relationship, and you're not overdoing tests, but the business model of healthcare goes around people needing procedures and needing medications. And so, but right now, all of healthcare is changing to where hospitals and organizations are responsible for keeping people healthy, and that the financial incentives are around that instead. And so as healthcare institutions are more responsible for people's health, they're starting to realize what we've realized, which is, geez, why don't we do something to their house? Or maybe they're calling 911 because they're lonely. Or all of these other things that people used to ignore, even if they kind of knew it. Because before there was no incentive to spend that $60 or that $70 to prevent someone. But now as more and more organizations come together and have a global budget, there's not what people call a wrong pocket, where, oh, but that's a housing pocket and we're healthcare. Those are starting to come together. However organizations can keep people healthy is the wave of the future. And so I'm not going to go through all of these policy possibilities, but I'll just give you the one that's in Maryland. It's very exciting, and it's a little bit of an extreme case of what I'm talking about, but just gives you a glimpse of the future. So in Maryland, all of the hospitals got together in the whole state and applied to CMS that runs Medicaid and Medicare and said, we've got an idea. We would like to have our same budget for next year. So let's say from Blue Cross and Medicaid and Medicare and Anthem, any health insurer, let's say when we put together all our billings, we bill, let's say, $10 million, this hospital does, and this one does $15 million. We want to know, guaranteed, that we'll get that same amount next year, even if we have fewer people in the hospital. And CMS is very interested in this because they're interested in different new ways. So they've granted what's called a waiver to the Maryland hospitals to gather together to do this. So and it's a slow transition. They've got all kinds of milestones, and it's a little more complex than I'm telling you. But basically, now the incentives are going to be reversed, exactly reversed. Hospitals will make money if they are a ghost town, right? If someone says, yes, I'll give you $10 million, and whether you see someone or not in the hospital, you bet you that you're going to think of, oh, let's have an asthma clinic in the school so people won't have to miss school and their asthma won't get out of, they won't be in our emergency room. Or let's, I've had people knocking on my door now talking about fall prevention. Can you give capable to people so that they won't end up in our hospital? Yes, I can do that. And so I know I said I would talk about fall prevention. Wojtek talked about how fall prevention has to not just be about physical activity, not just be about Tai Chi. If you look at what we do, it's all fall prevention. It's looking at their medications. We check their vision. Their environment, their stairs, their lighting, their rugs, and then we also do strength and balance. That's what's needed in fall prevention, is multidisciplinary but around their own motivations, as Wojtek was saying. So there's all kinds of, we're just at such an exciting moment in healthcare. And for those of you who are just starting out, I really encourage you to use your own clinical insights or theoretical insights, or whatever your disciplinary background is, and think, how can I change the world for older adults now, given what I know and what I can bring to the table to other disciplines, with other disciplines, and leverage this really exciting moment now, even though there's no NIH funding for anything. Yeah. And so I want to acknowledge our funding and our co-investigators. I know some of you are colleagues with some of our folks, and an amazing team of occupational therapists, nurses, handy people, data collectors, and that's all, and I'd love to answer any of your questions. Yeah.
Can you talk about whether the effectiveness of the intervention varies? I know it's particularly when you're talking about Mrs. D, and I'm coming from the perspective of a family sociologist who studies later life, particularly parents and adult children, whether the effectiveness of the intervention varies by marital status or the presence of, not necessarily living with, but
right.
Regular contact with adult children.
Right, so the question, in case you couldn't hear it, was does the effectiveness seem to vary with the presence of adult children, or whether people live alone or not? And so we have not looked at that systematically yet. About half of our participants live by themselves, which is a little higher than the national average. From a perspective of just being, hearing a lot of the stories and being on a lot of the home visits, in my mind, and from what I've seen, family members can be all across the spectrum in terms of helpful or not. Sadly, family members are humans just like all the rest of us, right? Some relationships are absolutely helpful and supportive, some are not. We've had some situations where the people were victims of intimate partner violence or too much control. We've had ones where people are almost disabling their relatives in a nice way, saying, "Oh no, don't do that. Don't get up. You just stay right there, and I'll do everything for you." That can be disabling too. So I don't have evidence to tell you, but I can tell you it seems to really be helpful or hurtful, all along the spectrum. But maybe you have a different, if you want to add.
Well, actually, I study within family variations in parent-adult-child relations, and so that's what we focus on, is that there's huge variability, usually even within the family, in terms of kids who are helpful, kids who are problematic.
Right. I would agree. I would agree. Yeah.
Thank you.
Yeah.
Why does she want to wash her hair, right? Like, there's that whole social dimension. So I'm wondering how you plan to couple up, or what plans there are. Now, obviously, we've got a lot of your plate right now, but as you demonstrate the improvement of function, or even some of those aesthetic things you mentioned, like maybe someone would really care about having their, like you said, a lot of it right now is focused on proving that function can be increased and maybe proving that costs can be cut down, which are really, really important things. What attention is being given, especially since this program is getting attention and getting well funded, to the social dimension of why people are improving function in the first place, why they want you to live longer and
Right. I mean, that's a great point. And a lot of times the goals end with something about social. So they'll say, I want to be able to, my goal is to get down my front steps into my daughter's car so I can go to church. Or I want to be able to walk to the Walgreens and get a gallon of milk and walk back so I can see my neighbor, so that the Indian relative, neighbor says, "Are you okay?" So a lot of the goals, they're functional goals to be able to be involved in something, or stand long enough to be able to cook so I can cook a meal for my grandchild, or there's a lot of that. And from my very pragmatic policy standpoint, maybe I give short shrift to the social, because I'm thinking, what would a congressman care about? And a congressman would care about, there are exceptions, but when we have tight budgets, congressmen would care about the money and maybe some good stories. But if you said, well, 80% of the people now are going to church or not, that doesn't move dollars as much. But it doesn't mean that it's not really incredibly meaningful and that we don't work with other colleagues who work on those issues. Absolutely. Absolutely. That's a great point. Thank you. Yeah, point time.
Can I just make an observation? First of all, I thought that was one of the most brilliant talks I've heard, and I learned so much. But that what you're doing with the functionally impaired and older people is really something that really we can apply across the life course.
Thank you.
It's about problem solving and goal setting and engaging individuals in those kinds of activities. And it's just enlightening and extraordinary, and I congratulate you.
Well, thank you. It's all just common sense, really, but thank you. Thank you. Yeah.
Thank you. As an older adult, this is exactly what I've been looking for. Ask me what I need, what I think I need. Don't put me in a town.
Right.
Don't ignore.
Right.
Don't put me in a big blanket. I'm an individual.
Right.
Thank you.
Oh, thank you. And the only times we've really gotten in trouble in terms of someone not working well is in the very beginning. We were a little too stubborn about safety issues. And so, for example, with like scatter rugs, in the very beginning when we were still piloting this, sometimes we would say, okay, we need to work on your goals, but you've got to get rid of this rug. And we learned pretty fast. It's their home, they're an individual, they live there, we don't. You can talk about it. You can say, I'm worried this might move if you, or it's much better if we say, I'm worried if a friend of yours come over, they might fall on this rug. That's much more effective. But absolutely. Absolutely. Yeah. Right, right. Thank you, and I completely agree, and I have been involved with some national home care organizations and helping them work on their standards, and also we are currently not in a fight, but in a friendly tussle, perhaps, in Maryland with, there is a benefit called Community First Choice, where people who are basically nursing home eligible, they can get some help, some homemaker help, or some, and they keep saying we don't need capable. We've got all this people can do for you, and we've got home modification. And we keep saying, yeah, but if you do our approach, the people will keep what they can do for longer and be happier. Yeah, go ahead. Mm-hmm.
If they aren't doing the labor themselves, but helping the person they're going to do it for themselves, it would be rewarding for everybody in the
I completely agree. And one of the things that we've found is that the nurses and the occupational therapists never want to have a different job. It is so rewarding to them to see someone over 4 months get better. And because if you work in the hospital, you just see someone briefly. If you work in outpatient, you might see them, every 3 months or something. But to work with someone who is pursuing their own goals and getting better is just nobody. We can't get rid of anybody. We've got no turnover. And so when grants end, it's quite sad because they. That's why we have to take over the world with this approach so they can keep their jobs. Yeah.
So to extend this model a little bit, a colleague at Indiana University, who's the medical director in a nursing home, has, I guess if you call it a resident-directed model, which parallels this in many respects, but that he and the care team comes in and talks to the residents about what are your goals. They're dealing now with post-acute cases to individuals who are coming to the facility from the hospital. What are your goals and what can we do to maximize those, as opposed to, as you were saying earlier,
Right.
the whole team talking to the person,
Right.
giving them prescriptions. So I think
That's
this kind of model can, as you mentioned earlier, can work across the spectrum.
Absolutely.
Even in a setting where people are quite functionally disabled and dependent on that institutional environment. And the goal here, the ultimate goal, is that for the individual is to be discharged from the facility and go home. And how do we bring that about, and what specifically is important for you?
Absolutely. And we're working with colleagues in New York City who are part of a really wonderful home health care agency. And when I was first talking to them, they said, oh, you know what, we asked people's goals, and they did an analysis, and they found that 75% of them were about function. But they do their regular home health care, like take your medicine. And so and I think it's required now. Home health care has to ask functional goals, but then they don't connect the dots and address them. So that's wonderful to hear that other places are doing that. Yeah.
Aren't the home care people restricted from time so often? They're limited by time and productivity.
Yes. Absolutely. And I think one of the things, yeah. And I think, hopefully when we've got cost data, we'll be able to show that spending the time can save the overall system money. Similar with house calls, by nurse practitioners and physicians, people think of them as really expensive because you're having the clinician do the driving instead of the older adult. But the information you get is priceless, in terms of the environment. And so there's a whole new movement for primary care providers doing house calls. Yeah.
I just had a question. You spoke a little bit about the funding aspects of it and kind of the policy of it. I was, as far as the government kind of paying the hospitals and reducing that, but as far as kind of the landscape of the future, I guess, perspective kind of look, how do you see, if there's going to be some sort of pushback from people who want to keep making money? Because, obviously it's a
Right.
business model that's
Right. Well, so I think there's enough sick people and enough older people that will be fine, because sometimes people say, what about the nursing? Are the nursing homes going to come out to get you? Or I've got a cousin who's a political science professor, and she's like, who are your natural enemies? And so I don't have too many natural enemies that I know of, but I think the baby boomers are going to really take care of the problem you're talking about in terms that there's going to be so many more older adults so quickly that it's going to take an all-of-the-above solution, and that we're going to have the old models of care and the new models of care and newer models of care, and that I think if we were kind of in a steady-state population, that your point you're making would be more threatening to some of these new ways of thinking. But hopefully, there's room for everybody.
We'll have to stop there. Thank you so much.